Welcome to the MRCpology channel for a quick review and understanding of the topic. Imagine a patient with advanced HIV who presents with several weeks of headache, low-grade fever, vomiting, and blurred vision. On examination, they are drowsy, but the neck stiffness is surprisingly mild. The key question is whether this is bacterial meningitis, tuberculous meningitis, viral encephalitis, or an opportunistic fungal infection. In an MRCP setting, advanced HIV with a CD4 count below 100 and a chronic meningitis picture should immediately make you think of Cryptococcal Meningoencephalitis. Cryptococcal Meningoencephalitis is an opportunistic central nervous system infection caused mainly by Cryptococcus neoformans, and less commonly Cryptococcus gattii. It classically affects patients with severe T-cell immunosuppression, especially advanced HIV. The disease causes chronic meningitis and often produces markedly raised intracranial pressure. To understand the pathophysiology, think of it as an aeroflow sequence. The patient inhales the yeast. It may then remain as a latent pulmonary infection. Later, when T-cell immunity is impaired, the organism spreads through the bloodstream and enters the central nervous system. The polysaccharide capsule is very important. It helps the organism evade phagocytosis, so the immune system struggles to clear it. This leads to a high organism burden, especially in patients with AIDS, where the inflammatory response may be surprisingly weak. Once Cryptococcus reaches the meninges, it tends to involve the basal meninges. Infection around the basal meninges impairs cerebrospinal fluid resorption. Cerebrospinal fluid then builds up, intracranial pressure rises, and this explains many of the clinical features: headache, vomiting, papilledema, sixth nerve palsy, diplopia, and visual symptoms. Clinically, the presentation is usually subacute rather than sudden. Patients may have headache, fever, malaise, nausea, vomiting, and photophobia. But a major MRCP trap is that meningism may be mild or even absent in AIDS. So do not exclude cryptococcal meningitis just because the neck is not very stiff. As disease becomes more severe, patients can develop confusion and reduce consciousness. This reflects meningoencephalitis rather than simple meningitis alone. Diplopia and visual symptoms are important warning signs because they suggest raised intracranial pressure or cranial nerve involvement. Cryptococcoma can occur, particularly with Cryptococcus gattii, although meningitis remains the classic presentation. And diagnosis depends on lumbar puncture, but always think about safety first. If there are signs of mass effect or severe focal neurology, brain imaging may be needed before lumbar puncture. When lumbar puncture is performed, the opening pressure is often high. This is not just a diagnostic detail, it is also a management issue because raised intracranial pressure can be life-threatening. The cerebrospinal fluid usually shows a lymphocytic or mixed pleocytosis, raised protein, and low or normal glucose. However, in AIDS, the CSF may be only minimally inflammatory because the immune response is impaired. That is another exam trap. A relatively bland CSF does not rule out cryptococcal infection in a severely immunosuppressed patient. The key diagnostic test is cryptococcal antigen in the CSF. It is highly sensitive and specific. India ink can show encapsulated yeasts, but it is less sensitive than cryptococcal antigen testing. Fungal culture confirms the diagnosis, although it takes longer. Serum cryptococcal antigen is often positive and can support the diagnosis, especially in advanced HIV. Treatment has 3 phases: induction, consolidation, and maintenance. Induction treatment is with liposomal amphotericin B plus flucytosine, usually for 2 weeks. The aim here is rapid fungal clearance from the central nervous system. After induction, consolidation is with high-dose fluconazole, usually for around 8 weeks. Then maintenance fluconazole is continued until immune reconstitution has occurred. In an HIV patient, this means the patient must be clinically stable and have adequate immune recovery on antiretroviral therapy before maintenance therapy is stopped. Raised intracranial pressure must be treated actively. The key intervention is repeated therapeutic lumbar puncture to remove cerebrospinal fluid and reduce pressure. Do not rely routinely on steroids or acetazolamide for raised intracranial pressure in cryptococcal meningitis. In exams, repeated therapeutic lumbar punctures are the important answer. Another major MRCP trap is the timing of antiretroviral therapy. You might think that ART should be started immediately in any opportunistic infection, but cryptococcal meningitis is different. Starting ART too early increases the risk of cryptococcal immune reconstitution inflammatory syndrome, which can worsen intracranial inflammation. ART is usually delayed for about 4 to 6 weeks after starting antifungal therapy. So the key clue is advanced HIV, CD4 count below 100, subacute headache, raised intracranial pressure, and mild or absent meningism. The investigation clue is high opening pressure with positive CSF cryptococcal antigen. The management step not to miss is amphotericin B plus flucytosine, repeated therapeutic lumbar punctures for raised intracranial pressure, and delayed ART. Do subscribe to the channel for further videos. Recall question 1. A patient with advanced HIV has subacute headache, vomiting, diplopia, and a high CSF opening pressure. The CSF cryptococcal antigen is positive. What is the induction treatment? The answer is liposomal amphotericin B plus flucytosine. Recall question 2. In cryptococcal meningitis with raised intracranial pressure, what management steps should not be missed? The answer is repeated therapeutic lumbar punctures.